Now, why this chamber enlargement is important also is because of the reason that you will see many diseases of the left ventricle, like the left ventricular hypertrophy, which causes our aortic stenosis, systemic hypertension, coarctation of aorta, or hypertrophic cardiomyopathy, which can cause left ventricular hypertrophy, or diseases like mitral and aortic regurgitation, where volume overload causes the left ventricular hypertrophy. So there are various ways to differentiate the pressure overload from the volume overload. Similarly, there are many diseases which can cause the left atrial enlargement, let it be a hypertension or a LV dysfunction or a aortic stenosis or a mitral stenosis or any other disease like the restrictive cardiomyopathy, atrial fibrillation. There are many diseases which cause the left atrial enlargement. Similarly, there are many causes of right ventricular hypertrophy, let it be a pulmonary hypertension, which is the most common cause of right ventricular hypertrophy, followed by other congenital heart diseases like the pulmonary stenosis, tetralogy of Fallot, Epstein's anomaly. And similarly, there are various diseases which cause right atrial enlargement. Again, pulmonary hypertension is the most common cause of right atrial enlargement. Then we have diseases like tricuspid stenosis and regurgitation, tetralogy of Fallot, pulmonary stenosis. So any disease where right ventricle enlarged invariably leads to right atrial enlargement, and any disease where right atrial enlargement is there, there will be invariably right ventricular hypertrophy, except some organic tricuspid regurgitation. Now, the basic for all this, why I am telling, is the reason that many a time we see a normal ECG. When you see just a normal ECG, you can just comment that, you can tell that there are no chambers which are enlarged, that is the right atrium, left atrium, right ventricle, left atrium. However, there are very subtle clues sometimes in the ECG of a left atrial enlargement, like you see just a negative P waves in the lead V1, or sometimes in the lead 2 you just have a broader P wave. So you can just miss at times the small things, because this just suggests that there are some left atrial and ventricular enlargement, left atrial or right atrial enlargement. However, things like the ventricular hypertrophy, like LV, usually are not missed because they are very gross. They produce a gross QRS amplitude changes. Similarly, the right ventricular hypertrophy may have many other features which we'll discuss. So the important thing is that this chamber enlargement is very important in the ECG, because when you diagnose a chamber enlargement, you invariably leads to many differentials which can cause this chamber enlargement, and so you can narrow down your differential diagnosis. So with this thought in mind, I think we should focus on how to diagnose each of this chamber enlargement in ECG. Now my talk will take you through many of the images of many patients which we can discuss. So let's go through this first patients with ECG. So this ECG is of a 40-year-old man with paroxysmal nocturnal dyspnea. I think most of you will know what is a PND. That is when the patient lies down at night after 2 to 3 hours of sleep, the patient gets up from the sleep, he coughs out, and then again goes back to sleep. So this indicates there is a left ventricular failure. So a 40-year-old man with some form of left ventricular failure, and this is the ECG. I think I'll use a pointer. Yeah. So this is the ECG. I think the initial classes, Dr. Harnesh Bhatia would have told you how to determine the axis on this ECG. There are many ways to determine axis. There are actually 6 to 7 ways, from the easiest way to difficult way. However, for a beginners like many of you, where you want to know the axis, you just have to know that if there is a positive QRS in lead 1 and a positive QRS in lead AVF, it is a normal axis. So a normal axis is if you have a positive terminal amplitude in one and positive terminal positive deflection in AVF, it is a normal axis. Anything where 1 is negative and AVF is positive, that is this is negative, this is positive, it is a right axis deviation. You can just remember by the just a mnemonic that right people meet. So when you have this and this meeting each other, 1 and AVF, it means there is a right axis deviation, and left people deviate. So if you have a 1 which is negative, positive, and AVF which is negative, it means that there is a left axis deviation. But this ECG, for all practical reason, there is a normal axis, because both the 1 is positive, AVF is positive. However, this is not a very solid thing to determine axis, because many people may ask you, what is the axis number? So what is that number? how do you calculate the axis? So there are many ways. Again, Dr. Harnis would have discussed with you to determine the axis. So one of the ways is you see which lead is the most biphasic. If any lead which is biphasic, in this there are no biphasic waves. So this is a normal axis ECG. However, there is no lead which is actually equiphasic. Biphasic means equiphasic, that is equal positive and equal negative. So here it is very difficult to determine the axis. You can grossly say that the axis is normal, and any lead which is actually, if there is equiphasic, will be a lead AVL. Then you go to the lead which is most perpendicular to that lead. So 1 and AVF are perpendicular to each other. Lead 2 and lead AVL are perpendicular to each other. Lead 3 and lead AVR are perpendicular to each other. Now I am not going in detail in the axis determination in this class, because that itself is a very long class, or maybe if I have some time in the end or some other day, I'll definitely take you through the axis deviation through 6 or 7 very easy to difficult rules. Now the most important things which you should not miss in this ECG, which is a gross finding, is, can you see this lead V1? A lead V1, the P wave is usually always positive. So what does this negative P wave in lead V1 suggest? And if you see similarly lead 2, if you can see, this is a very gross finding. The P wave is a hump, a camel hump shape. Normally a P wave duration is not this much. If you can see, the P wave duration is almost 3 small boxes. So normal duration of a P wave is usually 1 small box. Here you can see from the beginning of P wave to the end of P wave, it is usually taking almost 3 small boxes, that is 0.12 millimeter, because 1 small box is 0.04 millimeter. So this is almost 0.12 millimeter, and the difference between the two humps, you can see normally the two humps you see is normally not very visible. Here you can see a hump. The first deflection is usually a left of the left atrium, and the second deflection is usually of the right atrium, because the left atrium is the one which get depolarized first, followed by the right atrium. The first deflection is of the left atrium and the second deflection is of the right atrium. Similarly, even a lead V1, the first positive deflection suggests the right atrium, and the second negative deflection suggests the left atrium. So these two things suggest that there is definitely some form of atrial enlargement in this ECG, and this negative V1 suggests that there is a left atrial enlargement, and this biphasic also hump suggests that there is a left atrial enlargement. Whenever you see a 40-year-old male with a paroxysmal nocturnal dyspnea and left atrial enlargement, the first thing which should come to your mind is always some form of valvular disease, mainly the mitral stenosis, where the left atrium is usually enlarged. But there are many differentials. Again, I'll just take you to a clinical hincher here, that whenever you discuss a differential diagnosis of cardiology, the 5 diseases should come to your mind, and this disease includes valvular heart disease, which is the most common, that is the mitral stenosis, aortic stenosis, mitral regurgitation, aortic regurgitation. Second is the cardiomyopathy. So the cardiomyopathy is like the hypertrophic cardiomyopathy are the one which causes the left atrial enlargement, whereas the restrictive cardiomyopathy produces a biatrial enlargement on ECG. Similarly, a dilated cardiomyopathy also produces a biatrial enlargement on ECG. The third diseases are the ischemic heart disease, that is the coronary artery diseases. The fourth group of diseases are the congenital heart diseases. So a 40-year-old male with PND, the PND is usually not observed in the congenital heart disease. And fifth group of diseases are the pericardial diseases, like the restrictive cardiomyopathy and the constrictive pericarditis. So this ECG in a 40-year-old male with PND suggests that there is a left atrial enlargement. Our always first focus should go on the other history, like a rheumatic fever, patient is on prophylaxis or not, and there is a definite left atrial enlargement in this ECG. Now again, going back to the next ECG, this ECG is of a 55-year-old gentleman with a NYHA class 3 dyspnea. Now, I think you all will be knowing what is the NYHA class 3 dyspnea, that the patient is not able to do even the household activities. So even the household activities like taking bath, combing, dressing, undressing causes dyspnea for the patient. Class 4 dyspnea is the dyspnea at rest. While sitting also the patient is having dyspnea. Class 2 dyspnea is less than ordinary activity, like if you are working somewhere, if you go for work, you are having dyspnea. Class 1 is very comfortable patient, some form of cardiac disease, but all the activities he is able to do. So this is the grading of dyspnea. So this patient is having class 3 dyspnea on exertion, and you can again see, again let's go from the limb lead. There is one is negative, AVF is positive, means to overall deflection. So this patient 1 and AVF. So there is a gross right axis deviation. Again, there are many equiphasic waves. If you see, all the waves are equiphasic. If you see lead AVF, the most negative to lead AVF is perpendicular to lead AVF is lead 1, and lead 1 negative means you have axis of almost more toward the right axis, that is you have around minus 120, so or minus 90. So you have near toward the minus 90, that is the right axis deviation is there in this ECG. So the normal axis is minus 30 to minus 30 to plus 110. So this ECG is going beyond plus 110, not minus 90, sorry, plus 110. So, but the easy way to determine axis is lead 1 is negative and lead AVF, the overall deflection is positive. So you say that there is a gross right axis deviation. Now again, there is, you can see that you have this broad P waves in the lead 2. It means there is a left atrial enlargement. This to differentiate a left atrial from a right atrial enlargement on ECG is a broad P wave in lead 2 suggests a left atrial enlargement, whereas the height of the P wave, if it is more than 2.5 millimeter or 2.5 small boxes, it means there is a P pulmonale or a right axis deviation. That is mainly because of the pulmonary artery hypertension. Whereas the broader P wave, it means there is a left axis deviation. Now to confirm this, let's go to the lead V1. Now lead V1 has both positive and negative here. So both positive and negative. As I told you, the first positive is right axis because the right axis gets activated first and followed by the left atrium. The right atrium followed by the left atrium is activated. Now this negative deflection can be suggestive of both the left atrial enlargement or the right atrial enlargement, which is also known as the pseudo LAE, that is the pseudo left atrial enlargement sign. Here there is definitely right atrial enlargement because if it is more than 1.5 millimeter in lead V1, the first positive deflection, or here if it is more than 2.5, then it is a left atrial enlargement. Here you see there is definitely the above one is enlarged, means there is a right atrial enlargement also. Now to know whether this negative deflection is because of the right atrial enlargement or the left atrial enlargement, you see the intrinsic coil deflection, or if the down tracing is steep or it is like this, whether it goes like this or like this. Here it is more falling perpendicularly, that the intrinsic coil deflection is very less. It is known as the right atrial enlargement or the pseudo left atrial enlargement sign, because normally in lead V1, if there is a negative, it means there is a left atrial enlargement. However, right atrial enlargement can also be there. This is known as the pseudo left atrial enlargement sign, and this patient has both the left atrial enlargement and the right atrial enlargement. One more thing which is very clear is a small q and a tall r. A small q and a tall r in V1 suggests that there is a right atrial enlargement. So I come to know all the points of right atrial enlargement in the ECG, but just this ECG when I am coming, you can just see that there is a small q and a tall r. So QR, small q, capital R, which is suggestive of a right atrial enlargement. It has very high sensitivity and specificity for a right atrial enlargement. So this patient has both the right atrial enlargement and left atrial enlargement, predominantly the right atrial enlargement on the ECG. So the learning point from this two ECG is that P mitral, this patient has both the P mitral and P tricuspidal, that is a P pulmonale. So QRS axis roughly correlates with the pulmonary hypertension. As I told you, lead 1 is negative, AVF is positive. So there is a right axis deviation, which means that there is some form of pulmonary hypertension in this patient. And RVH. Now, why did we tell RVH? There are many other features of RVH, like a right axis deviation indirectly reflects RVH. There is S1 in this ECG. Then QR, small q, capital R, indirectly suggests right ventricular hypertrophy. Then a positive R in V1 more than 7 millimeters also suggests right ventricular hypertrophy. Plus you see there is some strain pattern write RVH with strain, that T inversion is there in V2, V1, V3. It means there is a strain pattern. So this all suggests that there may be some form of right ventricular hypertrophy. Again, I told you QR in V1 and right atrial enlargement. All this suggests that this patient has some form of pulmonary artery hypertension. So this 55-year-old gentleman has some form of pulmonary artery hypertension. Why did we tell? Because there is a right atrial enlargement, there is a pseudo left atrial enlargement sign because of the right atrium, there is almost 2.5 height of the P wave, and then there is a right axis deviation. All this suggests that the patient may have some form of right ventricular hypertrophy or pulmonary artery hypertension. Now this ECG, again I'm going to the third ECG. I will take to all the theoretical part more towards the end of the discussion. Like, let's go ECG wise, where we understand more better the subject and the topic. Now this is an ECG of a 30-year-old lady with chronic cough, now in heart failure. Now a 30-year-old lady, if it comes with a chronic cough and heart failure, what all diagnosis we should think of is a very important thing. Like the first thing when somebody tells of chronic cough, young lady, is the asthma or COPD. So you can think that this patient has some form of bronchial asthma. Because of bronchial asthma, there is an involvement of the right heart, which can cause pulmonary artery hypertension. So both bronchial asthma and COPD in long term can cause pulmonary artery hypertension, or eventually the patient may have interstitial lung disease, which can cause hypoxia and pulmonary artery hypertension in long term. And now in heart failure, maybe mostly the right heart failure. Or you can also think the other way, this patient is chronic cough. Sometimes mitral stenosis patient can have chronic cough because of the orthopnea, PND, and they may present with the left ventricular failure. So any of this is possible. Let's see the ECG is telling what. So what is the axis in this ECG? Lead 1 is negative, lead AVF is positive. So right, again there is a right axis deviation. So first thing, important thing is there is a right axis deviation. Now what about the lead 2? Lead 2, there is no broadening of the P wave, there is no P pulmonale. So here we are not very clear. Let's go to the lead V1. Lead V1 has a prominent first positive deflection, suggesting that there may be some form of right axis deviation or right atrial enlargement. But then you see again there is some form of Q and R. The Q and R in V1, Q and R in V1 suggests that there is some form of right atrial enlargement. However, in lead V2, when you see there is more type of RBBB. Now this is what I will tell you. There is something known as Chow's classification of RVH, where there are 3 types of RVH: type 1, type 2, type 3. Type 1 is seen in classical forms of pulmonary artery hypertension, where you get a classical form of QR pattern in V1. However, sometimes the type 2 type, where you get RBBB and all, are more common in patients with atrial septal defect and other diseases, whereas type 3 is more common in patients with COPD and bronchial asthma. So this lady in ECG can have, because there is a right axis deviation, QR in V1 may have some form of pulmonary artery hypertension, which would have caused a right heart failure, apart from the chronic cough, maybe because of the bronchial asthma or COPD or interstitial lung disease. Now let's go to the fourth ECG. So this fourth ECG is of a cyanotic infant. I hope most of you know what is the cyanosis. Cyanosis is the bluish discoloration of skin or mucous membrane due to the presence of deoxygenated hemoglobin of less than 5%. So if you have a deoxygenated hemoglobin of more than 5% in the body, it is known as a cyanosis. Now cyanosis can either be a central cyanosis or a peripheral cyanosis. The cardiac diseases which can cause cyanosis are the tetralogy of Fallot, the Eisenmenger syndrome, or a diseases like some other respiratory diseases can be there, or pulmonary AV fistula. Pulmonary AV fistula is another one cardiac condition which can cause cyanosis, and there are many other diseases in cardiac which can cause cyanosis. However, the important thing in this ECG is, let's again go, lead 1 is, and most of the cyanotic heart disease, as per the rule you know is they have a right axis deviation. So lead 1 is negative, AVF is positive. Again there is a right axis deviation in this ECG. Whenever there is a right axis deviation, we tend to get some form of positive AVR, positive deflection in AVR. Now there is a RBBB in lead V1, and then there is sudden transition. So this sudden transition from V1 to V2, where there is sudden positive becomes equiphasing in V2, suggests that there is some form of tetralogy of Fallot in this ECG, which I am not going into detail. My entire this topic is more focused on the chamber enlargement, so I am not going to the individual diseases as per, but this cyanotic infant may most probably be having some form of cyanotic heart disease that is known as a tetralogy of Fallot. Now let's go to the, and which chamber is enlarged. Most probably there is a right atrial enlargement, because there is a right axis deviation. You can see that there is a P pulmonale. If you see the height of P, there is almost 3 mm, 1, 2, 3, almost more than 2.5 mm, means there is some form of right atrial enlargement and right axis deviation is there. So there is no RVH seen in this ECG, because with the presence of, or there can be some form of RVH, because to tell RVH you should have at least 11 to 12 mm of positive R wave. So if you see, this is almost 11 mm. In presence of RBBB, you need 11 mm of positive R wave in V1, whereas in absence of RBBB, even 7 mm is enough positive R wave to call it a right ventricular hypertrophy. So there is almost 11 mm of R wave in presence of RBBB, which suggests that there can be a presence of right ventricular hypertrophy. So this cyanotic infant has a right axis deviation, right atrial enlargement, and possibly a right ventricular hypertrophy, most commonly due to tetralogy of Fallot. Now let's go to another example of ECG, which is of a 28-year-old man with again class 2 dyspnea, NYHA. As I told you, class 2 NYHA means the patient is able to do his routine activities, but anything which is more than routine activity like office work and all those works are causing dyspnea to the patient. Now let's go to the axis. So most of this ECG are having a right axis deviation. Lead 1 is negative, AVF is positive. It means there is a right axis deviation. The most prominent thing is there is almost 3 mm P wave which is positive, which is upstroke. So it is a P pulmonale. So there is a definitely right axis deviation and right atrial right atrial enlargement in this ECG. But there is also something that is only a negative deflection. Now, as I told you, only a negative deflection in ECG with, if there is a positive deflection, there can be right atrial enlargement. This negative deflection can be because of the right atrial enlargement or the left atrial enlargement. As I told you, usually if there is a left atrial enlargement, it tends to follow this pattern. Here there is a very steep, very perpendicular drop of this P wave. It means it can be possibly a pseudo left atrial enlargement sign. So pseudo left atrial enlargement is a form of right atrial enlargement. We have a right axis deviation, we have a P pulmonale, and then we have a pseudo left atrial enlargement sign. Again means this patient may be having some form of pulmonary artery hypertension or a RVH with and a QR in V1 suggesting right atrial enlargement. So if this patient has right atrial enlargement, means either it can be due to RVH or it can be in absence of RVH. But most of the other findings in this ECG are going for a right atrial enlargement. So only disease which can have right atrial enlargement without RVH is usually organic tricuspid valve disease like a tricuspid stenosis, which is very rare. So most of the right atrial enlargement in the ECG are usually secondary to right ventricular hypertrophy. So the learning point from this ECG are there is a P pulmonale, there is a P congenital. So there may be some form of right other diseases which can cause the right atrial enlargement. And let's again go to the types of RVH, which I'll come into the subsequent slide. But so this is what I was focusing on. A steep negative P in V1 can still be right atrial enlargement, as is seen in this ECG. There is a steep negative P in V1. And the onset to the nadir of P wave less than 30 suggests right atrial. As I told you, from the onset to the peak, if it is less than 1 or less than 1 small box, it is still a right atrial enlargement. If it is a left atrial enlargement, the onset to the nadir of P will be more than 30 millisecond or 40 millisecond. And a steep inverted P is usually known as pseudo left atrial enlargement sign due to right atrial enlargement, and true left atrial enlargement is inverted with a slow slope. As I told you, there will be intrinsic or deflection like this, or the onset to the nadir will usually be more than 30 to 40 milliseconds. Now, let's go into the theory part, which we are discussing from very long. So, what are the various ways to diagnose right ventricular hypertrophy by ECG? There are n number of criteria. You need not know all 12 of this, but you should be smart enough to pick up the small things. Like, as I told you, in presence of absence of RBBB, if you have R in V1, which is more than 7 mm or 7 small boxes, it is suggest of right ventricular hypertrophy. So the first important thing what you have to see is there should be right axis deviation. You usually very rarely get a right ventricular hypertrophy in absence of right axis deviation. So right axis deviation is the foremost thing which you have to see in all patients with right ventricular hypertrophy. But in presence of RBBB, 0.7 or 7 mm is not the cutoff. It is the 11 mm which is the cutoff, or 15 mm. Sorry, some books say 11, some says 15. So the other ECG which I showed you is around 11 mm. It's just a borderline to say, but overall grossly 14 to 15 mm is usually the cutoff in presence of RBBB. Now QR, from last 4 slides we are discussing QR in V1, which suggests that right atrial enlargement. So right atrial enlargement indirectly shows that there is a right ventricular hypertrophy. Now there are some indirect signs like R by S ratio in V1 more than 1. So if R by S, R is always tall and S will be smaller, less than 2 mm. S will usually be less than 2 mm in lead V1. However, there are certain exceptions which will come in the subsequent slide. So if your R by S in V1 is more than 1 with R more than 0.5 mm, or R by S in V5, V6, when you go toward V5, V6, you see more of the S wave. So R in V5 or V6 is less than 1 mm. Again, it may suggest a right ventricular hypertrophy. If you have S in V5 or V6, which is more than 7 mm, just like R in V1 more than 7 mm, if you have S in V5 or V6, which is more than 7 mm, it indirectly suggests that there is a right ventricular hypertrophy. Or if your R in V5 or V6 is more than 0.4 mm, means 4 mm, with S in V1 less than 2 mm. So if your R in V5 or V6 is more than 4 mm, and S in V1 is less than 2 mm, again it is form of right ventricular hypertrophy. What I will tell you, don't go into very minute detail. The important point is 0.1, 0.2, 0.3 and 0.4 and 0.5. These 5 things you should remember. Means R in V1 is equal to S in V5, V6. So the cutoff is 7. QR in V1 suggests right atrial enlargement or right ventricular hypertrophy. In V1, the ratio of V1 R by S should be more than 1. In V5 or V6, the ratio should be less than 1. So these are the absolute numbers. Now let's go to some other things which indirectly suggest right ventricular hypertrophy or right axis deviation. I told invariably most of these patients will have some form of right axis deviation. Now there is something which we always talk is S1, Q3, T3. This wording S1, Q3, small s in V1, lead 1, limb lead 1. Q3, small q, and a T inversion in lead 3. We usually think that it is suggestive of pulmonary embolism, but it usually reflects right ventricular hypertrophy. The S1, Q3 and T3 usually suggest that there is a strain pattern on the right ventricular and it is suggestive of right ventricular hypertrophy. Again, as I told you, similarly a QR in V1 which suggests right atrial enlargement, a P pulmonale if you get. P pulmonale means the more the height of the P wave more than 2.5 mm in lead 2. If it is there, it is suggestive of right ventricular hypertrophy. Now in presence of RBBB, if your R dash is more than 15 mm, like the ECG which I am here, the R dash, it's not actually 15 mm, it's 10 to 11 mm. So it's just a borderline case, but the cutoff should be more than 15 mm to tell that there is a form of right ventricular hypertrophy. Cabrera index is a very complicated thing. I won't take you into this, but just this name, if somebody asks you, it is usually shown to represent a right ventricular hypertrophy. Now, this wording you would have heard many times for a case of left ventricular hypertrophy, Sokolow-Loyan. So Sokolow-Loyan criteria is used both for the right ventricular hypertrophy and left ventricular hypertrophy. More commonly for the left ventricular hypertrophy, where we say that the V1 plus V5 or V6, if it is more than S in V1 and R in V5, V6 if more than 35 mm. Most of you would have heard in left ventricular hypertrophy. It is suggestive of left ventricular hypertrophy. But Sokolow-Loyan also is there in the right ventricular hypertrophy. So if there are in V1 plus S in V5 or V6, is more than 10.5 mm, it is suggestive of a right ventricular hypertrophy. Again, like a left ventricular, V1 and V5 and V6 are taken. So it is the ulta. In LVH, there is more negative S wave. In RVS, there is more positive R wave. So R in V1 plus S in V5 or V6, if it is more than 10.5 mm, if suggested right ventricular hypertrophy. Now, Sokolow also has AVL criteria for left ventricular hypertrophy, where if your R in AVL is more than 12 mm, it is suggestive of left ventricular hypertrophy. Similarly, instead of AVL, this takes R in AVR. So as I told you, a right ventricular hypertrophy can also cause a positive R wave in AVR. AVR is usually a negative, where everything is negative. P is negative. AVR full QRS is negative, and T inversion are there. But if your R in AVR is more than 5 mm, it is suggestive of right ventricular hypertrophy. Or a R in V1 more than 7 mm, which we already know, or S in V1 less than 2 mm, which you already know. So usually with RVH, the R in V1 is more than 7 mm, S in V1 is less than 2 mm, or instead of AVL for LVH, you see AVR for RVH. LVH, the cutoff is 12 mm. For RVH, it is a 5 mm in AVR. Or the sum of values of R and S in V1 and V5, V6 is more than 10.5, it is suggestive of RVH. So Sokolow criteria, if you remember, it's good. Even if you don't remember, we have just all criteria for RVH. Now I won't go into again the Butler-Leggett formula. It is very complex thing. Just the name, if they ask you in some MCQ, you can just remember it is used for the diagnosing the right ventricular hypertrophy. Now, right ventricular morphology. This is the way, till now I just told you the numbers which can tell that there is a right ventricular hypertrophy. Now there are certain indirect clues to the right ventricular hypertrophy. One is the right axis deviation. I told you for all the right ventricular invariable, 99% of the patient will invariably have right axis deviation. Again, there is something known as ST changes or strain pattern, which I have showed you in this ECG. Here there is a QR pattern in lead V1, such as there is some form of right ventricular hypertrophy, but this is the strain pattern, RVH with strain. Because of the RVH, there is strain on the right ventricle, which is causing a ST depression more than 2 mm in lead V2 and V3. So this strain pattern also suggests that there is some form of right ventricular hypertrophy. Again, like LVS, if there is a delayed onset of intrinsic deflection, like there is a from in QRS lead pattern, it suggests right ventricular hypertrophy. Precordial voltage changes, as I already mentioned, 7 mm and 15 mm in presence of RBBP, and normal QRS deviation. Like a LVH, RVH also doesn't cause the prolongation in QRS duration unless there is a LBBB or a RBBB in case of LVH, or RBBB in case of LVH, RVH. So these are various RVH morphology which indirectly suggests that there is some form of right ventricular hypertrophy. Now this is something very important. In most of you, they may ask you, what are the various forms of RVH? So till now we were actually discussing about very typical form of RVH, which is due to pulmonary artery hypertension, where in all the diseases like the mitral stenosis or any form of disease like the MR, which causes a PH, or primary pulmonary hypertension, or any cause of pulmonary artery hypertension which puts a strain on the RV and cause RVH, and that is why that is a typical form, that is a type A, where you either get a tall R in V1 or a QR wave suggesting right atrial enlargement and a prominent S in V5, V6. So the typical form is seen in typical forms of PH in any valvular heart disease or Eisenmenger syndrome, where these features are seen. Now type B is usually seen in ASD and rheumatic heart diseases, severe PH which can cause, where you get an incomplete RBBB. So you see many ASD patients, the typical ECG scenes are RBBB, and you know that ASD can cause right atrial enlargement, right ventricular enlargement due to volume overload, and some form of right ventricular hypertrophy. So in lead V1, you will see around R in V1 is more than 0.5 mm and ratio more than 1, but there is normal QRS in V5, V6. There won't be a prominent S in V5, V6. It will be a normal in V5, V6. I think one of the ECG we have discussed, not this one. This is a typical form. on this one. Yeah, I'll show you a ECG where we have a type B. And then type C is because of a chronic lung disease, any form of lung disease like a ILD, bronchial asthma, COPD, where there is a RS pattern in V1, V2, or capital R, capital S pattern in V5, V6, and the ECG changes are due to RVH and both the anatomical shift of the heart. We know that in COPD and bronchial asthma, both the chamber enlargement and the anatomical shift of the heart causes a ECG changes. So mainly in the lung diseases, that is a type C. Now this is a type C RVH in patient with COPD. There is a small RS pattern. We know that there is a small R. This patient has a small R and a deep S pattern, and you see that in V5, V6 there is a R and a S pattern. Both R and S are there. So you see that this is due to COPD or lung diseases where there is a small R, deep S, and equal R, equal S in V5, V6, suggesting that this is a type C RVH. So this is a Chow's classification. So you can determine various types of RVH based on the morphology. In type 1, it is a proper V1 has V1 has more than 7 mm, and V5, V6 S is more than 7 mm. That is mainly due to PAH and typical diseases. And in type B, if you see a RBBB pattern and there is no changes in V5, V6, it is due to type B, or diseases like the atrial septal defect. Whereas the type C or the lung diseases, you will have a small R and a deep S with a equal R, equal S in V5, V6. So these are the various classifications of RVH. Any doubt till now? I'll just wait for 30 seconds before just proceeding further. Siddesh, you have anything in your chat box?
Nothing, sir.
So either people understand or people don't understand. One of them. I hope I'm not going very fast now.
No, it's totally fine, sir.
Yeah. Okay. So if anything is there, you can just put in the doubt box, or you can put it in the end so that we can have a good discussion. Now I'll go to little bit more detail. So again, the next ECG is of a 4-month baby with heart failure. Now from the adult, we have come to a baby with a heart failure, and right, yeah, little fast for the beginners. Yeah, don't worry. What I'll do is I'll revise it in the end. And also what I'm going through in the next ECGs will be the repetition of actually what I'll be in of the previous ECG, or I can again do a small revision in the end 15 minutes. So yeah, that's what I told you. Whatever I told you is actually related to your previous classes and the axis determination. So that is the most important thing. I'll try to do a revision in the end. Okay. So let's go to the next ECG, a 4-month baby with heart failure of 1 month. Now let's again revise up. Let's again brush up what we have discussed. Now, again, this ECG, as you see, has equal positive one is equiphasic, 2 is avial equiphasic. So we can determine the axis that there is some form of right axis deviation in this ECG. Now, what is this? Again, is a very obvious thing. This is something known as Himalayan P wave, something we call, which is seen in Epstein's anomaly. But there are many other diseases which can cause a P wave which is equal to the QRS. They are usually known as the Himalayan P wave, which is a typical feature of Epstein's anomaly. But if you see this ECG, there is a P wave which is almost 10 mm. We have a cutoff for 2.5 mm for P pulmonale, that is a right atrial enlargement. But now when you come to this side, you see that there is a right atrial enlargement, but there is also a negative thing. Now I again told you the negative deflection P wave in V1 can be a right atrial enlargement also, or a left atrial enlargement also. So to differentiate the right from the left, we have to see that the deflection is a fast or slow. So here, if you see this deflection in the P wave is actually very fast. It's not going like this. It's almost going from the initial to terminal. It's almost one box only. So less than 30 milliseconds. So this is actually some form of right atrial enlargement. And this patient, this child, 4-month baby, has some form of Epstein's anomaly. When you see this ECG, you should think that this tall Himalayan waves suggest Epstein's anomaly. Okay, now there are people who can again argue with me on this ECG that there is a left atrial enlargement also, that this enlargement is not because of the right atrial enlargement but the left atrial enlargement. There are no actually other features of left atrial enlargement much which I can see. So this ECG is usually 4-month baby with heart failure. Epstein's anomaly usually present. If you have given the word cyanosis, it will be more easy. A cyanotic baby with a heart failure, right heart failure is usually. But if you feel that there is this deflection is of a left atrium, then you can also argue with me that there are disease in the childhood like a restrictive cardiomyopathy or a dilated cardiomyopathy or a multivalvular heart disease. Again, in a 4-month baby, multivalvular heart disease is out of question. So if this patient is an adult where you have both a biatrial enlargement, so biatrial can be in restrictive cardiomyopathy, dilated cardiomyopathy as I already told, or multivalvular heart diseases which can have both the right atrial enlargement and the left atrial enlargement. But this high P waves are usually suggestive of Epstein's anomaly in an infant. Now again, learning point from this ECG, tall, again that's what I told you, tall peaked P waves are suggestive of right atrial enlargement. There is no doubt on that. However, the wide inverted P waves in V1. Now again, as I told you, somebody can ECG never tells a diagnosis to you. ECG can only tell the chamber enlarged or a soft finding. So if you think that this P negative in this, it is a left atrial enlargement, you can argue with me that there is a biatrial, because in lead 2 there is a right atrial enlargement, in lead V1 there is a left atrial enlargement. So if 4-month baby is having a biatrial enlargement, why a 4-month baby should have a biatrial enlargement? One cause can be myocarditis or a dilated cardiomyopathy or a restrictive cardiomyopathy due to various storage disorders in a small kid, or a multivalvular heart disease that I'll keep out of this because valve diseases so early do not happen in a small infant. Now, what can give you clues to the diagnosis is if you have a small QRS complex. This QRS complex you see are not low voltage. If you have a biatrial enlargement with a low voltage QRS, it is suggestive of infiltrative disease like the amyloid. However, in this case, there is a preserved QRS voltage. The P, it's not a low voltage. Low voltage means it is less than 5 mm in the limb leads and less than 10 mm in the chest leads. Here, the limb leads and chest leads both are preserved. It means there is no low voltage complex. So if you have a preserved QRS voltage complexes, other RCM, non-amyloid RCM like the RCM and DCM should be considered, and amyloid can be ruled out. So you can say that there is a biatrial enlargement in this ECG, and a 4-month baby can have a restrictive cardiomyopathy or a dilated cardiomyopathy. Now let's go to the right atrial enlargement. Till now I was discussing about right ventricular hypertrophy, but let's go to the right atrial enlargement. Now most of this we have already discussed in few of the slides. Again, I told you I'll brush up, or I'll again tell you about the same thing again and again. So what are the various things which tells that there is a right atrial enlargement? Let's come to this. Now, this is the first point. A P pulmonale, any positive P wave with a height more than 2.5 mm in lead 2 and more than 1.5 mm. Here there are so obvious. There is a very huge right atrial enlargement. If it is more than 1.5 mm in lead V1, it is suggestive of right atrial enlargement. If it is more than 2.5 mm in lead 2, it is suggestive of right atrial enlargement. So these two things are very obvious. P wave in lead 2 more than 2.5, in lead V1 more than 1.5. So this is definite. Now increased area under the initial portion more than 0.06. Now how do you calculate more than 0.06? You don't have to anything. It is the height into the box. Here it is very obvious that the height is almost 8 mm and number of boxes it includes is almost 2 mm. So 8 mm into 2 is almost 0.8 into 6 is 1.6. So the cutoff for area under that curve is actually 0.06. So it just suggests that there is some form of right atrial enlargement. Now, if there is a rightward shift of P wave axis, now I think in your previous classes you would have heard of the QRS axis as I'm talking again and again. it is very difficult to determine a P wave axis. A P wave axis is very difficult to calculate. It is usually given by the computer. So you have to see all the P waves in the 6 leads. This is positive, this is positive, this is all are positive except lead AVR and AVL. So there are two leads which are actually negative here. There are two leads which are negative. If there are all 5 leads are positive and only AVR is negative, it means the P wave axis is normal, and the normal P wave axis is 45 to 75 degree, or some people say 0 to 75 degrees. Normal P wave axis. You cannot calculate P wave axis by yourself. It is usually a computer generated axis, and a axis beyond 75 degrees suggests that there is a rightward axis of the P wave, which means there is some form of right atrial enlargement. Similarly, if the P wave axis is negative, that is minus 30 or beyond 0 degree, it is suggestive of a leftward axis because of a left atrial enlargement. Now this is something which I have been talking again and again. A QR pattern in V1 is suggestive of right atrial enlargement. So a QR pattern in lead V1, again I'll show you few ECG. We have been discussing it again and again. QR, can you see? So Q and R, a Q and R in V1 suggests that there is a right atrial enlargement, and this sign has 100% specificity for a right atrial enlargement. Now, this is something which is very important thing. A low amplitude QRS in V1, which becomes 3-fold or more in lead V2. Now, this is one way to differentiate a left atrial enlargement from pseudo left atrial enlargement. So as I told you here, if you see, I told you it can be a pseudo left atrial enlargement sign, but you can also comment on that there is a true left atrial enlargement. But if you see the height of QRS, which was almost 8 mm, became almost 30 mm. So there is so much increase in QRS amplitude from lead V1 to V3. So if there is a sudden increase in amplitude from V1 to V2, more than 3-fold, it suggests that there is a right atrial enlargement in the ECG. That is what. So this is one way to differentiate a right atrial enlargement from pseudo LAE sign. So according to me, this was a true right atrial enlargement because there is sudden increase in QRS duration. You see QRS, not duration, voltage. Almost it is 3 times it has increased between V1 and V2. So it is suggestive of a right atrial enlargement. We have been discussing this again and again. Severe right atrial enlargement, there is a prominent terminal negative deflectivity, that is from the peak to the nadir. Earlier terminal negativity from the peak to the nadir is less than 30 millisecond in right atrial enlargement, whereas it is more than 30 to 40 in left atrial enlargement. So you have to differentiate a true left atrial enlargement from a pseudo left atrial enlargement, which is due to right atrial enlargement. So these are the 8 points we have discussed in the last 6 ECGs. If anybody has any doubt, you can just stop me and just ask me this doubt. I am very happy to clear this. Now, as I told you in the first slide, the various causes of right atrial enlargement. Right now, I told you start from the valvular heart disease. So which valvular heart disease can cause right atrial enlargement is tricuspid stenosis, tricuspid regurgitation. But any disease which cause pulmonary hypertension like mitral stenosis, which can cause pulmonary artery hypertension and can cause right atrial enlargement, or a congenital heart disease like a pulmonary stenosis, tetralogy of Fallot, or Epstein's anomaly, or any lung diseases like a COPD, ILD, pulmonary embolism, those type of things, or any disease like a bronchial asthma or a pulmonary embolism can cause right atrial enlargement. So if somebody asks you what are the various causes of right atrial enlargement, you should be able to tell at least these are the various causes of right atrial enlargement in ECG. So let's go to the left atrial enlargement sign. So again, this is the same thing I have been telling in the last 4 ECGs. How do you tell that there is a left atrial enlargement? So as I already told you, it is the right atrium which first gets deactivated, followed by the left atrium. Because you would have, I think you would have heard in your last all classes this thing that how does the action potential goes from RA to LA, then from the from the SA node to AV node to His bundle, Purkinje fibers and to the left ventricle and then the right ventricle. This is how the action potential moves, and that is why you first get a right atrial enlargement in lead V1 followed by a negative terminal deflection, which is left atrial enlargement, or in lead 2 the first hump is usually of the right atrium followed by the second hump is of the left atrium. So there are two humps. If they are very prominent, it means that there is a left atrial enlargement. So this is the first thing, a prolonged P wave duration more than 120 milliseconds. So I told you a normal P wave is of a height less than 2 mm and is of a width around one small box, that is 40 milliseconds. However, if your P wave duration is increased beyond 120 milliseconds, it means that in lead 2, it means that there is some form of left atrial enlargement. Similarly, the hump which I am telling you in your lead 2, let's go if we have anything in the, so this is the first ECG, which is a classic ECG. You see that the duration, the first point of that is left atrial enlargement was this. 1 box, 2 box, 3 box. This P wave is usually an abnormal P wave. However, this P wave is actually a normal P wave. You see, it is almost actually just one small box or less than 2 box. So this is a normal P wave. However, this P wave is an abnormal P wave because the duration of P wave is 1 box, 2 box and 3 box. So more than 120 milliseconds. It's a very broad. It means the left atrium is dilated. So this suggests that there is a dilatation of the left atrium. And the second point, I'll again come to that. If you see there are 2 points, this is the right atrium and then this is the left atrium. So right atrium is small, however the left atrium is so big that the second point is usually so big. So the duration of 2 notches, the duration between the 2 humps, it is more than 40 milliseconds. Or if you see there is any visibility of a hump in lead 2, it suggests that there is a left atrial enlargement, because it is very difficult to make out this points. It is definitely around 40 milliseconds. So the difference between the 2 humps in this lead 2, it is more than 40 milliseconds, suggests that there is some form of left atrial enlargement. The third and the fourth point are index, which is called a Macruch index and the Morris index. The easier one is the Morris index. So Morris index is, if you see here, there is no right atrial enlargement, there is only negative deflection. Again, I'll go, this is a classic negative deflection. As I told you, is it a right atrial enlargement or pseudo left atrial enlargement due to right atrial enlargement? You see from the tip to the nadir, there is so slow it is moving. So it is due to the left atrial enlargement. If it was like this, it was a right atrial enlargement. If it is like this, it is a left atrial enlargement. And you see it is so deep and so broad. So the Morris index says that the depth divided by the width, if it is more than 0.04, here it is 1 box, 2 box, almost 3 box. If you see, starts 1 box, 2 box and 3 box, means 0.12 millimeter, because 1 box is 0.04. So there is duration is 0.12 millimeter and the depth is 2 boxes. So 0.12 into 2 is 0.24. The cutoff is 0.04. It means 1 box breadth, 1 box depth. If it is that much, it is enough to qualify for a left atrial enlargement. So any negative deflection in lead V1, if you see like this, it is suggestive of a left atrial enlargement, and that is what is known as a Morris index. I will try to finish the Macruch index here also, which is very complex and is very difficult to calculate. So the Macruch index, these two indexes suggest left atrial enlargement. It is very easy to remember Morris index. Again, I'll go in the other figure. This width divided by the depth of the P wave. Width is 0.12 mm. You see from here to here, there are 3 small boxes. Depth is more than 1 box. There are 2 boxes. So 0.12 into 2, 0.24. This is Morris index. Cutoff is 0.04. Now Macruch index is the duration of P wave. So P wave duration here is 3 boxes, as I already told you. 0.12 divided by the duration of PR segment from here till here. So from here, ending of the P wave till the R wave, the duration is almost, actually it's 2 boxes or 0.08. So 0.12 divided by 0.08 is almost 1.5, 1.6, 1.5. So cutoff for Macruch index is 1.6. It suggests left atrial enlargement. So let's go and discuss it with a good ECG. Let's come to left atrial enlargement. Now, the easier one I have told you, Morris index. I have again and again emphasized on the Morris index through that ECG. And the Macruch index is the ratio of P wave duration in lead 2 divided by the duration of PR segment. And if the cutoff is more than 1.6, it is suggests the left atrial enlargement. Similarly, I told you the axis of P wave, which we cannot calculate normally by ourselves. We have to take the help of ECG generated P wave axis. The normal axis is 0 to 75 degree. Beyond 75 is right atrial enlargement. Less than 0 degree or minus 30 to minus 40 is left atrial enlargement. So your computer generated ECG will tell the axis of P wave and the positive P terminal force in AVL. Now this is very important. The positive P terminal force in AVL, if it is more than 0.5 mm, it suggests left atrial enlargement. I think this point is something which you can avoid at this. The first 5 points are the points which are important for left atrial enlargement. The 2 important things I'll again focus in next 2 minutes. Morris index. Now you see this is a amplified version of the any ECG. Now Morris index, again I told you, go to lead V1, see the P wave. This is very obvious. If you see any negative P wave in V1 without a positive P wave, it means that there is a left atrial enlargement sign or a right atrial enlargement. Here you see then the intrinsic deflection. From here to here it is more than 30 milliseconds, 40 milliseconds. It means it is left atrial enlargement. Now you see the duration between this and 2. 1, 2, 3. So A to B is 0.12, whereas the depth is 1, 2 boxes. So it is 0.12 into 2, that is 0.24. So as I already told you, 0.04 is the cutoff for that, right? So this suggests that there is Morris index. This is the Morris index. So if any doubt, again I'll come back to the Morris index. I think we have something in chat box. Okay, which is more severe, LVH or RVH? Okay, let me then I'll finish this class and then talk about this, because it's not about the severity. Let's finish it. So this was about the Morris index. Now let's go to the Macruch index. Again, as I told you, it is in lead 2, you go to the duration of P wave to the duration of PR segment. So this is actually a magnification of the first ECG which we were seeing actually. So this is the duration of the P wave: 1 box, 2 box, 3 box, 4 box. So from here, 1 box, 2 box, 3 box, 4 box. So the duration of P wave are 4 small boxes. It means 1.6 mm or 0.16 millimeter, I think, because one is 0.04. And duration of PR segment, if you see, it is only 1 box from here till here, from here till here. So if you do the ratio 1.6 divided by 0.4, or so it almost goes to 4. So 1.6 is the cutoff. We have 1.6 as the cutoff. So 0.04 divided by 0.16 is equal to 4. And the cutoff of P to PR segment is 1.6 for Macruch index. So this ECG qualifies for the left atrial enlargement both by for Macruch index, and this ECG qualifies for the left atrial enlargement by Morris index. Now let's come to the left atrial enlargement. Now I have told you there are many causes of left atrial enlargement. The most common is the valvular heart disease, which is the mitral stenosis and mitral regurgitation, aortic stenosis. Then we come to the hypertensive heart disease, which can cause left atrial enlargement. Hypertrophic cardiomyopathies can cause isolated left atrial enlargement. Then our other diseases like restrictive cardiomyopathy can cause biatrial enlargement. Dilated cardiomyopathy can cause biatrial enlargement. So the typical disorders are this which can cause left atrial enlargement on ECG. Now again, I'll just stop. I think I should answer the question which I had there. So which is more severe? Now I don't know, the question is about the severity by ECG or severity by clinically. So if you have a RVH, both way it is worse. It depends on the diseases which are causing this. So LVH, if you see the disease which is causing this, if it is only hypertension, it's again a bad sign, because a LVH in hypertension means your end organ damage has happened. The end organ damage means cardiac is involved by your hypertension and left ventricular hypertension. The way you see in eyes, retinopathy, you see albuminuria by kidney, you see renal failure is there, you see diabetic like nephropathy, neuropathy. Similarly, when LVH is there in ECG, it means obviously LVH will there be on echo. It means the patient has left ventricular hypertrophy and end organ damage has started occurring. Similarly, other diseases like the aortic stenosis, which causes the left ventricular hypertrophy. When the aortic stenosis causes left ventricular hypertrophy, it means the disease has progressed to that level that patient will need now the surgical intervention like aortic valve replacement. Now, other diseases which can cause left ventricular hypertrophy are the HOCM, which is actually a malignant disease. It's not a very normal or a light disease. Or any diseases like the mitral regurgitation or a aortic regurgitation. When you go to right ventricular hypertrophy, the disease are the either a pulmonary artery hypertension, which itself have a very bad prognosis, or a left heart disease which cause pulmonary hypertension. Mitral stenosis, when it causes pulmonary artery hypertension and RVH, again it means the disease has progressed very much in its course. Or any other diseases like RVH, like the top physiology or a pulmonary stenosis. So you cannot tell just by this thinking which is more severe, RVH or a LVH. It depends on the disease which is causing RVH and LVH. Just by ECG, if you tell which is more severe, RVH or LVH, I think it's not sufficient to answer this question, because it depends on the disease which is producing this RVH or LVH. Right? Any other questions are there, Siddesh?
Yes, sir. We do have some couple of questions, sir.
Okay.
First is how to differentiate left from right atrial enlargement.
How to differentiate left from right atrial enlargement? So I have been talking about this only from last many slides, that a right atrial enlargement is so a right atrial enlargement, we have so many things. First, it will produce a P pulmonale, that is in a lead 2 more than 2.5 mm P wave, and a lead V1 it is more than 1.5 mm V wave. However, like the other ECG which I told you, shown in this, if you have a isolated negative deflection, isolated negative deflection in V1 which is and there is a terminal deflection is more, it means there is a left atrial enlargement. However, if you have both positive and negative deflection like this, the negative can be because of the right atrium or the left atrium. Just one second. It can be because of the right atrium and can be because of the left atrium. Now, terminal deflection, if it is happening very fast, it is right atrial enlargement sign. However, this is typically suggestive of the left atrial enlargement sign. To confirm this, you go back to lead 2. In lead 2, if you have a bifid P waves, it's called a bifid P waves like this, it is suggestive of a left atrial enlargement. In lead 2, if you have a tall P wave, height more than 2.5 mm, it is suggestive of left atrial enlargement. So these are the few things to differentiate a right atrial enlargement from the left atrial enlargement. Again, how to differentiate right atrial ventricular hypertrophy and left atrial and ventricular hypertrophy. Not able to understand what is how to differentiate right atrial. If you want to differentiate a atrial hypertrophy from a ventricular hypertrophy, in left it is very easy. See, I am just coming to the ventricular hypertrophy of left. Left ventricular hypertrophy is the most easiest to differentiate among the four, because it has a very high QRS voltage criteria. The QRS voltage will be very high. However, when you come to the left atrial enlargement, it's not called hypertrophy. Left atria is usually enlarged, whereas the left ventricle can be enlarged or hypertrophied, which will come to it. Left atrial enlargement produces the change, as I told you, a bifid P waves in lead 2 and a negative deflection in lead V1. The Morris and Macroich index will be positive. Now, when you have a right atrial enlargement and right ventricular hypertrophy, how do you differentiate? As I told you, all the diseases which causes right atrial enlargement will invariably have right ventricular hypertrophy, except if you have an organic tricuspid stenosis or a regurgitation where only right atrium, or a Epstein's anomaly where only a right atria will be enlarged without a right ventricular hypertrophy. These are the diseases where only right atria is enlarged without right ventricular hypertrophy. So it is very easy to know right ventricular hypertrophy by all the criteria we discussed. You have a tall R in V1 which is more than 7 mm. You have a right axis deviation. You have a, in presence of RBBP more than 15 mm. You have a S1 Q3 T3. You have other things like RVH with strain pattern. V1 more than 7 mm and S in V6 more than 7 mm. R by S ratio in V1 is more than 1. So these are the things to know there is a right ventricular hypertrophy. Everything which have right ventricular will later on go to right atrial enlargement, but most of the diseases where right atrial enlargement is there will ultimately have, except rare diseases like TSTR and Epstein's anomaly, right ventricular hypertrophy. I think I am clear in this answers, right? And yeah, so with this I'll go to the last phase of the talk, which is about the left ventricular hypertrophy. Yes. Now the left, as I told you, the left ventricular hypertrophy. Now again, if you give me a choice which is more severe, RVH or LVH, again I may not be able to tell because it depends on the clinical condition which is causing RVH or the clinical condition which is causing LVH. Even if you have a small disease like hypertension, if it has produced a LVH in your ECG, you have to be very careful because it means that there is already a end organ damage which is happened. So that is one thing which is which I wanted to tell. Now, right ventricular hypertrophy is something which have again many diseases like mitral stenosis, pulmonary artery hypertension, top physiology, pulmonary stenosis, and many other things. So that is one more thing which I wanted to tell. Now let's go to the left ventricular hypertrophy. There are many diseases which cause left ventricular hypertrophy. Again, I told you hypertension is one of the disease. Second disease is the aortic stenosis. Third disease is a coarctation of aorta. Fourth disease is a hypertrophic cardiomyopathy. So these are the diseases which produce a load on your left heart. That is a strain pattern and cause left ventricular hypertrophy. Now there are different criteria for left ventricular hypertrophy. The most common criteria we use is actually the Romhill-Testis criteria, which I'll come in sometime. But before that, there are the easy criteria like the Sokolov-Lyon criteria, which most of you will be knowing. And even the most common thing which MBBS people use is the Sokolov-Lyon criteria. And then we have a Cornell criteria and modified Cornell criteria. So let's start with a criteria which has the highest sensitivity in diagnosing left ventricular hypertrophy. When you mean highest sensitivity, it means you are ruling out any other thing. So what is Cornell criteria? Let's go with the example of this ECG. You have to see two leads, AVL and lead V3. You have to add the R wave in AVL and you have to add the S wave in lead V3. After adding the R of lead AVL and S of lead V3, if the addition is more than 28 millimeter in males and 20 millimeter in females, it means that there is a left ventricular hypertrophy by Cornell criteria, and this has the highest sensitivity in diagnosing the left ventricular hypertrophy. What you have to do is add the R in AVL and S in lead V3. And if the sum is more than 28 millimeter in males and 20 millimeter in females, it means that there is left ventricular hypertrophy. Now, the Cornell has also come with a very easier version where you just have to see only one lead, which is the lead AVL. If you see a lead AVL and you see that there is more than 12 mm of R wave in lead AVL, it is suggestive of a modified Cornell criteria. The sensitivity is not much, because if you decrease the number of leads, your sensitivity will come decrease. You increase the number of leads with increased voltages, your sensitivity will increase. That is why cornell criteria, voltage criteria, has the highest sensitivity. But at times you can use the modified cornell if you want to just see one lead. Now, as I told you, the criteria which most of the people use, which is not actually very sensitive or specific, is Sokolow-Loyen criteria. We have discussed the Sokolow-Loyen criteria in right ventricular hypertrophy, but it is very useful in left ventricular hypertrophy. What you have to do is you have to see the S in lead V1 and R in V5 or V6. Only two leads you can see, V5 and V6. So S is seen only in lead V1. If the sum of S in lead V1 and R in V5, V6 is more than 35 millimeter, as it is very obvious in this ECG, there is a left ventricular hypertrophy by ECG. So S in lead V1 and R in lead V5 or V6, if it is more than 35 mm, it is suggestive of left ventricular hypertrophy. Now, let's go to a criteria which has the highest specificity. It means if this criteria are there, it has to be LVH. Whereas cornell has the highest sensitivity. It means if this criteria is not there, it cannot be LVH. So let's go to a Romhild-Estes criteria, which most of the people do not remember. Even at the higher level of things like you do MD medicine or a DM cardiology, you will realize that many people don't remember it. Why? Because it is very tedious to remember. It has 6 points, and those 6 points are very difficult to know. But this 6 points of LVH indirectly has points which reflect it. So it's very quite easy to remember, as I tell you. Now the first point is the amplitude of the largest R or S. Now if you see any limb leads, if the largest R is more than 20 millimeter, or if you see any chest lead where R or S is more than 30 millimeter in the chest lead and 20 millimeter in the limb lead. If you have a S in V1 or V2 or R in V5 or V6, so the tallest R or S, if it is 30 millimeter in chest leads or 20 millimeter in limb lead, that carries a point of 3 points. Right now, second thing which carries 3 points is strain pattern. Like RV has strain, LV also produces strain on the heart by producing ST depression. Now, if you see this patient has ST depression, strain. Now, it can be in presence of this patient. If it is on digitalis, we do not consider it significant. If the patient is not on digitalis, digoxin can produce toxicity and digoxin effect by having T inversion. So if the patient is not on digoxin, we take it as a 3 point. If the patient is on digoxin, we take it as 1 point, because it may not be much significant. Then there are things like left atrial enlargement. As I told you, you see this, the negative deflection in lead V1. The negative deflection in lead V1, right here, there is some negative deflection, and if it is there, it suggests that there is a left atrial enlargement. It is more prominent in this lead. You see a negative deflection in lead V1 suggestive of left atrial enlargement. As I already told you, width divided by height, if it is equal to or more than 0.04, it is suggestive of left axis deviation, left atrial enlargement. Fourth point is the presence of left axis deviation. One is positive, AVF is negative, left people diverge. So there is a left axis deviation which suggests that there is you can give points for 2 points for left ventricular hypertrophy. QRS duration more than 90 milliseconds. So here if you see points like this, there is an intrinsic coid deflection. You can see, can you see this? This is called an intrinsic coid deflection. Normally it should be like this, but if you have this bizarre or a splintering, it means that there is the presence of LVH. So this suggests that there is a presence of intrinsic coid deflection in lead V5 or V6 that carries 1 point, and QRS duration more than 90 millisecond. Now, here it is very difficult. It's not all more than 90, it's around 80. So there are many points which are meet. Like if you have one wave where it is more than 1, 2, 3, 4, 5, 6, 30 millisecond, there is a left atrial enlargement, there is a left axis deviation. 1 is positive, 3 is negative. So there is left axis deviation. There is a strain pattern on this ECG. There is intrinsic coil deflection. Out of the 10 points, if you have 5 points, then it has a very high specificity for diagnosing LVH, around 83 to 97%. If your point is 4, we call it probable LVH, and if the point is 5, we call it possible LVH. So point 4 suggests the 30 to 50% sensitivity, whereas more than 5 point is means specificity is very high. So this 5 points I want you to remember. You should see the voltage, 20 mm in limb lead and 30 mm in chest lead, left atrial enlargement, left axis deviation, presence of a strain pattern, QRS duration more than 90 millisecond, and intrinsic coil deflection in V5 and V6. So I think these are the 4 important criteria to know the LVH by ECG. Beyond this, there are many criteria. I don't want you to go in deep. One of this criteria I'll tell you. Some people, what they do is all the precordial lead, they sum it. If the sum of all the precordial leads are more than 175 millimeter, again it will be suggestive of a LVH. These 3 are some complex codes which I don't want you to know because they are the complex and it's used only in some of the research papers. Now this was one criteria which was published 5 years back in Journal of American College of Cardiology, which is also known as Prestige criteria. What again they did 2 things. They took the S lead V4 S wave and any lead with the deepest S wave. So if any lead with deepest S wave and S wave in lead V4 is more than 28 millimeter in males and 23 millimeter in female, then it has very high specificity for diagnosing LVH. So this was one of the criteria. You can just remember S in V4 to any deepest S in V1 to V6. If it is more than 28 in males and 23 in females, it is suggestive of left ventricular hypertrophy. Now sometimes you have a LBBB on ECG and you have to diagnose left ventricular hypertrophy. This is just for your curiosity. I'll tell you, it may not be much relevant at your level for beginners purpose, but just for curiosity I'll tell you. So this is one place where you have to see the AVL. I told you don't see only isolated AVL, but in presence of LBBB, if you see that AVL is more than the tallest R in AVL is more than 11 mm, then you can diagnose LVH in presence of LBBB. Or your S in V1 and R in V5 or V6, S in lead V1 and R in V5 or V6 is more than 40 millimeter, then is suggestive of LVH in presence of LBBB. Or a S in lead V2, if it is more than 30 millimeter, or S in lead V3 is more than 25 millimeter, then it is suggestive of LVH in presence of LBBB. Similarly, can you diagnose LVH in presence of RBBB? So these are few of the points. However, again, you should remember one thing. In presence of RBBB, you will get right axis deviation. However, in presence of RBBB, if you get a left axis deviation, you should always rule out LVH. Now the points which are there is maximum R and S in precordial leads. If any of the maximum R or S is around 30 millimeter, you can take 29 or 30 millimeter with left axis deviation, then you have to think that in presence of RBBB, there is a LVH. Like in presence of RBBB, if there is a left axis deviation with precordial has around 30 millimeter R or S, then it may be suggestive of LVH. Or S in lead V1 is more than 2 millimeter. Normally, I told you in presence of RBBB, the S will never be more than 2 millimeter. It will always be less than 2 millimeter. However, you have a S which is more than 2 mm in lead V1. You should always consider thinking of LVH in presence of RBBB. Or a R in V5 or V6. Normally in LBBB, you have a R in V5 which is heighted. In RBBB, you have a S, a deep S in V5 V6. However, instead of S in V5 V6, you get a R in V5 V6 which is more than 15 mm. Then you should consider thinking of LVH in presence of RBBB. So these are few of the points which you should know how to diagnose LVH in presence of LBBB. Now there are three causes, important causes of pressure overload are the hypertension, aortic stenosis, and volume overload are like the mitral regurgitation, dilated cardiomyopathy, and aortic regurgitation. So can you distinguish volume overload from pressure overload? There are 3 points. A pressure overload will not produce a deep Q wave in V5, V6, whereas a volume overload will produce the presence of a Q waves in V5, V6. Q wave which are more than 2 mm in V5, V6 suggestive of volume overload. So you should think of diseases like dilated cardiomyopathy, mitral regurgitation, aortic regurgitation. Similarly, if you have a tall R wave in V5 and V6 in presence, strain pattern suggests pressure overload. Always remember. If you have ST depression in V5, V6, it is suggestive of pressure overload. If you have a tall T waves in V5 and V6, it is suggestive of volume overload. So these are the points to distinguish a pressure overload from a volume overload. So here I would like to end my topic. If any doubts are there, I will take it. Thank you. Hello?
Yes, sir.
Right. So any questions in the chat box? Anybody? Any doubt?
No, sir. No questions, sir.
Right. So anything from your end, or anybody has in chat box, we'll just wait for a minute and then before wrapping up. So what I actually wanted to convey is chamber enlargement by ECG is an important thing which all of us should know. But before ECG, you should also know the chamber enlargement by chest X-ray. But this topic is because it is about the ECG. The first thing is, it is very difficult to miss out a LVH in ECG because most of us will know so obvious high voltages. But it is very easy to miss out left atrial enlargement on ECG. Similarly, it is very difficult, not very difficult, not to pick up right ventricular hypertrophy and right atrial enlargement on ECG because there will be some soft clues or markers to the presence of that. Plus, left atrial enlargement is something which you should always keep in mind because many times in clinics you will see patients who have present with dyspnea and all, and you see that ECG is done nothing but a left atrial enlargement. Always should suspect diseases like mitral stenosis if not a patient is not a hypertensive. So you should think of those diseases in mind when you see a negative terminal deflection in lead V1, which is usually suggestive of LVH in hypertensive disorder. But in valvular heart disease, you should always consider mitral stenosis when you see a left atrial enlargement in ECG. When you see a right atrial enlargement in ECG, RVH, again you have to think of either a congenital diseases or a pulmonary artery hypertension or diseases like COPD, bronchial asthma, which can cause PAH, or mitral stenosis, which can cause PAH. So these are the things I think you should keep in mind in ECG.
Right. Sir, we have one question, sir. Like, is heart failure and LVH are same?
No. See, heart failure is a clinical diagnosis. LVH is a ECG diagnosis. Many diseases with LVH can produce with heart failure, like hypertension can produce with heart failure, aortic stenosis can present with heart failure, MR, mitral regurgitation, aortic regurgitation, which can cause LVH with volume overload, can present with heart failure, but they are not synonymous. Heart failure is a clinical diagnosis, LVH is a electrocardiographic diagnosis. So what is the changes in ECG in case of pulmonary hypertension? As I told you, pulmonary hypertension is one thing which first involves the right ventricle. So it produces a right ventricular hypertrophy in ECG. So right ventricular hypertrophy, the first thing you have to see is R in V1 more than 7 mm, or any features of right ventricular hypertrophy like the right axis deviation. Then you will have R in V1. Then you have a strain pattern, means tall R in V1 with ST depression in V1 to V3. Then you have other features like S1, Q3, T3. You may see features like that. So those are the features. And then you have a right, and then indirectly it will go to and enlarge the right atrium in the long term, not in the acute term. Then you'll see features of right atrial enlargement like the P pulmonale, QR in lead, V1. So those are the things which you have to see in patients with pulmonary artery hypertension.